I'd like to now present our next speaker, Dr. Tingting Li. She is a nephrologist and associate professor of medicine at the Washington University School of Medicine. She's also a member of our Amyloid Center of Excellence at Washington University. And today she's going to discuss the presentation, diagnosis, and management of kidney involvement in amyloidosis.
Thank you, Keith. It's a pleasure to be here. Let me share my slides. Just want to make sure, can everyone hear me and see my slides?
Yes, very good.
All right. Well, thank you to Dr. Lanahan and the planning committee for organizing such a wonderful amyloid symposium. I certainly have learned a lot this morning. In the next 20 minutes, I wanted to give a quick overview on renal amyloidosis. All right, so these are my disclosures, and none of this is relevant to the talk today. A brief outline for the talk. Now, renal amyloidosis results from misfolding of proteins, which then self-aggregate and deposit in the extracellular tissue of the kidney as insoluble fibrils. These fibrils are quite resistant to degradation, so they remain inside the kidney, and that can cause disruption of the kidney tissue structure, as well as causing direct toxicity to the kidney tissue. And this can result in progressive kidney dysfunction and ultimately renal failure in many patients. Now, amyloidosis can be limited to the kidney alone, but more often it's part of a systemic process in which multiple organs are affected. There's no uniform definition for renal amyloidosis. The International Symposium on Amyloid years ago defined kidney involvement in AL as the follows: renal biopsy evidence of amyloid, along with clinical or laboratory evidence of organ dysfunction, or biopsy evidence of amyloid elsewhere, plus a 24-hour urine collection of more than 500 milligrams of protein per day, and most of that should be albumin. And as you know, there are more than 30 proteins that have the amyloidogenic properties that can have the potential to undergo misfolding. Listed here are the forms of amyloidosis that commonly involve the kidney. In several forms, the kidney is actually the predominant organ that's involved, and that it has implications in is a significant source actually of morbidity in these patients. When we look at patients with the AL amyloidosis, kidney involvement is quite common. Up to 80% of patients would have some degree of kidney involvement. Now, kidney involvement is variable in AA amyloid, but in one study, more than 97% of their patients had some degree of kidney involvement or kidney dysfunction. ATTR is the increasingly recognized form of amyloidosis. The wild type ATTR actually is not usually associated with kidney dysfunction, but the hereditary ATTR can be associated with kidney disease in up to 50% of the patients. And this depends on the mutations that these patients have. And V30M mutation is the most commonly studied, and it is thought to be the most common mutation that's associated with kidney disease. And there are at least 10 other variants that can also be associated with kidney disease. This is data from the Mayo Clinic looking at 474 patients with renal amyloidosis. As you can see, the AL is the most common, followed by AA, and followed by several of the hereditary forms of amyloidosis. As you can see here, ATTR, no one here actually has ATTR-associated kidney disease. In a different series, actually this is from Arkansas, looking at 285 patients who underwent renal biopsy and showing renal amyloidosis. Only 4 patients had a ATTR diagnosis. So it's quite rare in actually at least in the nephrology clinic, I have only seen 1 case of amyloidosis attributed to ATTR. Renal amyloidosis in general is quite rare. This is data from Switzerland looking at renal biopsies over a couple of decades. As you can see here, the prevalence of renal amyloidosis is quite low, and the overall prevalence is about 1.6%. So why do most amyloid proteins like the kidney? Why do they have such a high affinity for the kidney tissue? We don't actually understand, but there's some theories, one of which is that the amino acid sequence of the protein might play a role in that, in determining the tissue tropism. The type of mutation in hereditary amyloidosis may also determine the affinity to the kidney tissue. There may be a couple of kidney-specific factors. For example, glycosaminoglycans of the glomerular-based membrane have been noted to promote amyloid formation, and that might explain, at least partially, why the kidney is an organ that's frequently involved. And the other kidney factor is the mesangial cells. These are the cells that are native to the kidney. They're located within the glomerulus. Interestingly, they like to actually take up light chains, and they process them into the amyloid fibrils and then kind of spit them out into the extracellular space and where it deposits. And then this might explain a little bit why AL has such a high frequency of renal involvement as well. How do patients with renal amyloidosis present? Well, it kind of depends on the type of amyloid they have. If you look at this data from Mayo Clinic, patients with amyloidosis tend to be older, in their 60s, except for AA. Patients here are slightly younger. And there's often a male predominance in all forms of amyloidosis here. When looking at the renal dysfunction at the time of presentation, AL amyloidosis or immunoglobulin-derived amyloidosis actually is associated with the best kidney function at presentation. But patients with AL amyloidosis have the highest degree of proteinuria and also highest frequency of nephrotic syndrome. Patients frequently present with edema, and this can be a result of nephrotic syndrome or advanced kidney failure or heart failure. Patients who have severe renal dysfunction may present with decreased urine output, but very rarely they may present with increased urine output. And this is in the setting of nephrogenic diabetes insipidus. And how that happens is that the amyloid infiltration of the interstitium around the distal nephron actually can create ADH resistance, and patients can have this form of DI developing, which this is quite rare though. Occasionally, patients can present with new onset hypertension as a result of vascular involvement by the amyloid. And the hypotension is actually way more common than hypertension in our patient population. And this is due to either advanced heart failure or due to autonomic dysfunction. And of course, many patients have multi-system symptoms, and they will present with symptoms associated with other organs. On lab data, what we see as a nephrologist, the most common is proteinuria. This can range from minimal to massively nephrotic. Frequently, patients will have very low serum albumin, renal dysfunction of varying degrees. Blood in the urine is commonly seen as well. And occasionally, we see a case of Fanconi syndrome, and this is when amyloid infiltration affects the function of the proximal tubules. And sometimes we can see hypernatremia, high sodium levels, and that's a result of a nephrogenic DI, which I just discussed. Now, on imaging studies, we always get a renal ultrasound when patients present to us for evaluation of proteinuria or renal dysfunction. When we see large kidneys on the ultrasound, we think about, we have a few differential diagnoses. Amyloid is always one of them. But most patients with renal amyloidosis do have normal-sized kidneys. Now, diagnosis of renal amyloidosis can occasionally be straightforward, but many times very complicated and require comprehensive workup. And we frequently collaborate with our colleagues in oncology, in cardiology, neurology, GI, to try to come up with the correct diagnosis. And when the patient presents with proteinuria, especially when they present with nephrotic range proteinuria, amyloid has to be one of your differential diagnoses. This is especially when they also presented with systemic symptoms, especially with heart failure, neuropathy, or unexplained GI symptoms. And we have a number of laboratory tests that we order frequently to work up proteinuria, to rule out other causes of proteinuria. But the specific testing here is usually dictated by the history and clinical presentation of the patient. But ultimately, the definitive diagnosis is based on a renal biopsy within the kidney tissue for light microscopy, electron microscopy, and immunofluorescence. And I'll go through each of these briefly. Amyloid can affect any compartment in the kidney, more frequently the glomeruli, but also the interstitium, the tubules, the blood vessels. Not only does it affect the cortex, but also the medulla. In fact, there are at least one form of amyloidosis that I know that only affects the medulla. And if you do a kidney biopsy, it doesn't get deep enough, you may miss the diagnosis. And looking at how each type of amyloid affects the different compartments of the kidney, you can see here that AL amyloidosis really affects the kidney, the glomerulus, very frequently, as opposed to other forms of amyloidosis, such as ALEC2 or amyloidosis associated with the apolipoprotein A1, 2, or 4. These forms of amyloidosis more commonly affect the interstitium, and sometimes the glomeruli are actually not affected at all. And on urinalysis in these patients, you may not see any protein or blood at all. Renal pathology, there are either suggestive features or diagnostic features for amyloidosis. This is light microscopy. You can see that this is the glomerulus. Inside the glomerulus, you can see this amorphous eosinophilic material that's deposited in the glomerulus. They are nodular in appearance, not unlike what you would see in diabetic nephropathy, but there are other techniques to distinguish the entities. Here's amyloid infiltrating the interstitium, amyloid in the blood vessel wall. And in this particular case, the amyloid is everywhere throughout the kidney in all compartments. Amyloid protein, as you know, has a high affinity for Congo Red. So this is what we see on a light microscopy after staining with Congo Red, this classic salmon color under cross-polarization. You can see that the classic and diagnostic apple green birefringence. Now, Congo Red, obviously, is a very specific test, but in the kidney, it's not 100% insensitivity, about 87 to 98%. So if you have a negative Congo Red test, you really cannot rule out amyloidosis. And electron microscopy often helps us in making the diagnosis of amyloidosis. Here you can see the deposition of amyloid in the kidney on higher magnification. Excuse me, sorry. On higher magnification, you can see these fibrillary structures, and these are the fibrils amyloid. They are straight, non-branching, randomly arranged, usually measuring about 7 to 12 nanometers in diameter. When you see this on electron microscopy in the kidney, this is a diagnostic of amyloid. Of course, with Congo Red and electron microscopy, you are able to make the diagnosis of amyloid, but you are unable to tell the type of the amyloid. The immunofluorescence testing or microscopy is the third component of renal pathology. This can help us in subtyping of amyloid, such as in AA or AL. At our center, we do immunostaining for light chains, and we actually don't do immunostaining for other types of amyloid. In this picture I'm showing you right in front of you, you can see that this is an AL patient with a very clear light chain restriction, a lambda restriction. There's no staining for kappa at all. As you already know, that the lambda protein light chain is more amyloidogenic than the kappa. So most cases of renal amyloidosis in the AL setting is due to a lambda light chain protein. Now, immunofluorescence is also highly specific for detecting AL amyloidosis. However, the sensitivity is only about 70 to 80%. So if you have a negative immunofluorescence and you have a positive Congo Red or amyloid on electron microscopy, it doesn't necessarily mean that you do not have AL. So in those cases where your immunofluorescence is negative, we usually send our kidney tissue for laser microdissection and mass spectrometry. Dr. Ritter will be discussing this further in his talk that's coming next, so I won't go into the details about this, but just want to say that mass spectrometry is highly sensitive and specific for typing of amyloid proteins. Now, treatment of amyloid, renal amyloidosis, it really varies with the type of amyloid. Unfortunately, for many forms of amyloid, we do not have effective treatment. Obviously, the mainstay of therapy is to target the underlying process, and this has been discussed previously by previous speakers. But just to quickly mention, the goal would be to either reduce the load of precursor proteins, or to prevent fibril formation, or to degrade the deposits that have already been deposited in the kidney tissue. Various therapies have been either discussed or will be discussed later today by speakers, so I won't go into them in detail. As a nephrologist, I actually usually we manage patients in a supportive fashion. We defer to our cardiology colleagues and oncology colleagues to treat the underlying amyloid. The general supportive measures are, there are a few that I want to mention here that are quite important that the nephrologists manage many of these. So for volume control, as I mentioned before, many patients present with volume overload for various reasons. Patients often will need a loop diuretic for volume control. Obviously, the type of loop diuretic is important because of the volume overload status, the gut edema. Many times we want to choose a loop diuretic that is more bioavailable. We also wanted to watch for resistance to diuretics because due to the nephrotic syndrome that many patients have, the low albumin in the serum, we might need a much higher dose of loop diuretic than that's required for example, for heart failure. In many cases, we may need to add a thiazide diuretic to enhance the effect of the loop diuretic. Of course, salt and water restriction is quite important. For patients with proteinuria, we would like to start the patient on some type of RAS blockade, such as ACE inhibitor or ARB. But oftentimes, these medications might be limited by hypotension in someone who has heart failure or by someone who has a severe autonomic insufficiency with hypotension. Blood pressure control has been discussed by Dr. Cates. There are more patients with hypotension than hypertension. Management of hypotension can be quite challenging. It's really, we look at them on a case-by-case basis. Patients who are nephrotic or severe nephrotic with a very low serum albumin are frequently at risk for hypercoagulable state for DVTs or PEs. And we closely monitor them for development of these events, but due to the increased risk of bleeding in amyloid patients, so we actually do not advocate for prophylactic anticoagulation in these patients. Of course, a subset of patients would progress to chronic kidney disease, and we would like to monitor their kidney function very closely, and also to manage other aspects of CKD, such as their bone health and their anemia, and then ultimately determine the need for renal replacement therapy. These patients are quite complicated, and management of these patients is often based on a multidisciplinary approach. Now, what is the prognosis of patients with renal amyloidosis? As mentioned by Dr. Merlini, in AL amyloidosis, the renal response correlates very well with the hematologic response. If you're able to achieve complete response or very good partial remission, the renal response will be much better compared to those who do not achieve at least a very good partial remission. And patients who do achieve at least a very good partial remission, which is the bottom curve here, will be much less likely to progress to ESRD and require dialysis. On the same token, patients who have good renal response, which is the bottom line here, they are also less likely to progress to ESRD requiring dialysis. Reduction in proteinuria also correlates with patient survival. You can see here in AL patients, if you have a more than 95% reduction in proteinuria, the survival of patients is significantly better. But there is a graded survival benefit. Even if you don't get 95%, you get 75%, that's still better than 50%. There are also some baseline predictors for ESRD in AL patients, namely proteinuria more than 5 grams a day or eGFR less than 50 at presentation. And if patients do not have either one of the predictors, their risk of progressing to ESRD requiring dialysis at 3 years is essentially 0. But if they possess both predictors, the risk at 3 years for dialysis is about 50%. Now, predictors for ESRD have also been studied in AA amyloidosis. The amyloid burden is important. The larger the burden, the more likely the patient will progress to ESRD. As I mentioned before, AA amyloidosis commonly involves the kidney. Now, the duration of inflammatory disease and also the serum creatinine presentation are also important predictors for ESRD in this patient population. Now, once patients progress to ESRD, our treatment options may include dialysis or renal transplantation. And patients who end up on dialysis don't actually do very well. This is data from Australia and New Zealand, looking at median survival of patients with amyloid who are on dialysis. Patients who are on dialysis. You can see here the survival of amyloid patients with ESRD was significantly inferior than that of patients who have ESRD due to other causes. If you look at the patient survival, renal amyloidosis patient survival, comparing AA to AL, the AA patients do significantly better than AL. Looking at survival in the first year after starting dialysis, having AL amyloidosis and having cardiac involvement are two negative predictors of death during the first year. Now, renal transplantation is a reasonable option in a select group of patients. This has been best studied in AA and AL amyloidosis. In AL amyloidosis, after renal transplantation, their prognosis really depends on their hematologic response at the time of transplantation. If they have attained a complete remission or very good partial remission, the patient survival is significantly better compared to those who did not achieve at least a very good partial remission. Now, patients with AL amyloidosis after transplantation do significantly better, actually this decade compared to the last decade. The median patient survival after renal transplantation is about 10 years. Now, renal graft survival is also excellent, 94% at 1 year and 81% at 3 years. And this is my last slide. I just wanted to point out one important thing. This is data actually that was just published last week or last month. This is a very important point. This study looks at the renal transplant outcomes in patients with AA and AL amyloidosis. And their survival in this study was noted to be comparable to patients with diabetic nephropathy. So again, emphasizing that these patients can be very good candidates for renal transplantation. So to summarize, the kidney is a very common site for amyloid deposition. AL is the most common form of renal amyloidosis. A renal biopsy is the gold standard for diagnosis. AL patients' prognosis their renal response is highly correlated with the hematologic response, and their patient prognosis also correlates with hematologic remission. Dialysis and transplantation are potential treatment options for a selected group of patients with renal amyloidosis. Thank you very much for your attention.
All right, thank you, Dr. Lee, for that great deep dive into renal amyloidosis.